about the research that we've been doing, and perhaps in a slightly broader context. Now, we were chatting just before this meeting to the organisers, and I was saying that the last 6-7 months has been quite extraordinary for me, as I'm sure it's been for many of you in different ways. But for me, I'm an infectious disease clinical epidemiologist, and so in some ways I feel as if I've been training my whole life to have a purpose. I know a long time ago it was seen, infectious disease is a bit of a thing of the past, and actually it's all about non-communicable diseases now. But I worked first in HIV and then in public health more generally. And so a lot of what's happened in the last year has really been important in building on things that we've learned over the last 3 decades, as you just said. Now to move the slides. There you go. So in a pandemic, I'm going to talk about the kind of public health challenges we're trying to address. So the main thing I'm going to talk about is how to know your epidemic. I think we've had experience in the UK in particular that if you do not know how fast an epidemic is spreading, where it is, who's affected, it's very easy to get behind the curve very quickly. It gets out of control, and then it takes an enormous effort to bring that epidemic back down under control. And my general way of looking at that is, whatever the outbreak, whether it's a pandemic, a national epidemic, or a local outbreak of food poisoning or whatever, you have to know who's got it. You have to be able to describe it in time, person, and place. And that's what I'm going to talk about today. Of course, as a public health professional, I'm also interested in the response, how we promote health, how we protect the public through the right testing and safety and security, and how we provide the services that people need. And finally, and I think very much linked to health promotion and how we get change, is how do we get the right trust and education and communication with the public, with policymakers, from scientists, clinicians, public health people, right across that two-way communication with the public, so that people are confident and will make the changes that are necessary to bring this under control. So, how do you know your epidemic? Well, there's a number of approaches, and classically you have routine monitoring. You have the number of cases, you have the, if it's a serious condition, the number of admissions, the number of deaths. But you also need active surveillance, and I'll hope to explain why. So here you are, this is the data today from the UK surveillance that was published by the government. So you see, if you can see my cursor, these are the number of tests. There's the grey line is the capacity and the number processed. So lots and lots of testing going on, about 250,000 tests a day going on. Then the next is the number of cases. So this is from March right through to today, and as you may have heard, there were nearly 14,500 people were reported to have tested positive, reported in the last 24 hours. That graph, which shows this peak in April, May, of about 5,000 cases, new cases a day, then this steep decline, and then steep rise. Now, if this was a teaching session, I'd be asking you why that's happened, what are the explanations? But I'm sure you're all aware that back in March and early April, testing for cases was only available to people in hospital, people severely ill. So really, the number of cases that we were saying were around in April, May was, I wouldn't say it's meaningless, but it was only the most severe cases. We were missing the vast majority of cases, whereas now, with more extensive testing, we are getting more of those cases. But it is incorrect to compare what we're doing now with what we had then. You can look at the shape, but you cannot say that we've got more cases per day now than we had in April. I don't think that's true. You can look at healthcare, which might be more stable. So these are the number of patients admitted, this dark line at the bottom, admitted to hospital for care. So that's another indicator which might be a bit more stable if conditions for admission are stable, i.e. you admit the same kind of severity of disease. And then deaths. I mean, unfortunately, of course, death is a pretty definitive and is in this country pretty well documented and counted. Therefore, deaths in the early phases was actually our best indicator of how this was progressing, because the deaths where COVID was mentioned are recorded in this. And so you see that we are way, way below where we were in April. But the challenges of that are immense. The case reporting, as I've said, the supply of testing is one of the key limiting factors as to whether or not that's a useful surveillance method. Who has access to testing? Is it everybody? Is it only people with certain criteria in certain jobs, etc.? What's the eligibility? And who actually goes and seeks tests? In some conditions, people get very worried. My background's in HIV and sexual health, and there are some people who are sometimes perhaps rather rudely considered the worried well, who want testing very, very frequently, even though they've not been at much risk. And that can overwhelm testing capacity. And some people who actually do have symptoms and need to get a test don't seek it. So, and any shift in that health-seeking behaviour will alter what appears as to be the number of cases. Reporting and delays in case we've seen over the last week can cause quite a lot of chaos. We don't know when people were positive. And also the test's validity. If a test validity, that is whether or not it tests what it says it does. So if someone tests positive, are they really positive? If someone tests negative, are they really negative? If that doesn't change over time, then you can still use it to track. You can still use case reporting to track. But if the validity changes and you get a better test that picks up a higher proportion of cases, then that would also alter the apparent pattern of disease. There's also limitations with clinical data and with mortality data. So the summary really is that it's very difficult to interpret over time if you're just using these. So we need active surveillance. That's where I'm going to talk about this big study, which is the main part of my talk. So it's called the REACT study, Real-Time Assessment of Community Transmission. And this has been funded by the Department of Health and Social Care and is a collaboration between Imperial College, and we're helped and supported by Ipsos Mori, who are our logistics partner and who do the work of actually sending out tests and so on. So there's two parts to the REACT study. There's the what's called REACT 1, which is a study of the virus prevalence using swab testing and PCR tests on those. So people take swabs themselves and that's sent to a laboratory. And then REACT 2, which is the one I've had most to do with, is a study of the antibody seroprevalence in the community in England. So just to briefly talk about REACT 1. Now, if you were watching the news last week, reading the papers, you'll see there was a lot of reporting about this REACT 1 study, which is showing how common the virus is in the community. It's been going on since May, and about once a month, we are testing between 120 and 160,000 people. Now, the difference between this and the testing that I've just been criticising as a form of surveillance is this is based on a random sample of people in the community. So we get the sampling frame is a list of people who are registered with GPs in England, which covers almost the whole population. And then we randomly select people, invite them to take part, and we get quite a good response rate. And if they sign up either online or they phone up, they will then be sent a kit to take their own swab, to do a questionnaire, and then that swab is picked up by a courier and sent to the laboratory. And so we calculate the daily proportion of those that are positive. And that helps us to calculate the total numbers of positives in the community at any one time and to estimate this R number, the reproductive number. And so we've been doing this, and we've just completed this week the 5th round of this data collection. The high-level figures, I would say, are these that were published last week. So in early May, the prevalence of percent was less than 0.2. So it was uncommon in the population, let's put it that. And it went down further to the point where there were, I think it was 13 per 10,000. It was a very, very low prevalence. But then, as you'll have seen last week, between the 18th and about the 25th of September, the prevalence in the first half of this data collection period went up to this much, much higher level. So we now think that just about 0.5%, so 1 in 200 people in England are infected at the moment with SARS-CoV-2, which is an extraordinary increase. What this graph shows at well, both of them show these black dots are the actual numbers or the prevalence per day, and then these lines are curves that are fitted, modelled to the data, the best fit for the data. Going across sequential rounds, which we think is the best fit, then you show this R number going down, 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 and then up. And we're just seeing it go up. And actually, we're suggesting it's slightly flattening in the last bit of the data presented here. So the key findings or the key points about REACT-1 is it is able to track prevalence in almost real time. It takes 2 to 3 days to get the results back, and then we process the data. So we're able to report to government when the testing is going on a weekly basis of what the prevalence was 3 or 4 days prior to our report. We report on a Wednesday. We're talking about data up until that Monday. This was the first last week to show and demonstrate how big the recent increase was, and to really show that there was an increase. I think almost more importantly, because we'd already seen an increase in case reports. If you look at this chart on the left here, these are the age groups going across, and then these are the rounds. And you'll see the biggest prevalence is in the 18 to 24-year-olds, where it's gone up to nearly 1% in the most recent. But you see this increase in all age groups. It's not something that we're confining to these young people, and us older people are, immune or excluded or whatever, shielded from it. It's going into all age groups. In fact, there's been a 7-fold increase in the over 65s. This one on the right shows the regions, so southeast, northeast, northwest, London. So you'll see that the highest are in the northeast and the northwest at the moment, whereas earlier on it was London that had higher prevalences, as we know from the pattern of cases that were diagnosed. So that's the REACT-1. Now REACT-2 is a more complex study, really. So you may remember this sort of started because early on, maybe, yes, it was in April, the government announced that they were going to test hundreds of thousands of people with antibody tests, and this was going to get us out of this epidemic. Everybody would be able to do a finger prick test, find out if they were immune or not, and those that were could go back to work. I think that was wasn't quite expressed like that, but that was the idea. So they bought millions of these tests, and then everybody started testing the tests and said, well, they don't really work very well. In comes our REACT-2 study to try and say, okay, well, what do, not those tests particularly, but this kind of test, which is where people test themselves, are they any good? Can they be made to be used effectively? And would they be able not to tell individuals about their status, but to tell us how many people have been infected with this virus? If you're just testing for the PCR, the virus, as in the previous REACT-1 that I've just mentioned, it may only be there for a week or two, and therefore it's a snapshot of that point in time. But what's an antibody, which is developed when you have an infection, that will be sustained over a period of months, and therefore we can tell how many people in total, so the cumulative number of people who've been affected. So we broke this up into a number of sub-studies. Before we went out to test hundreds of thousands of people, we wanted to answer some questions. How accurate were these tests? They're called LFTs, lateral flow tests. And they don't really look like a pregnancy test anymore, but they're a little cassette, plastic cassette, and you drop some blood into one little hole on it, you put some buffer solution into another, and then you get a reading, which is a line or not a line. So we wanted to see, first of all, how accurate they were, and we did that in the laboratory using healthcare workers who we knew had been infected, who'd had a PCR positive test 3 or more weeks ago, and we got them to do these tests. We also took blood to do confirmation, and worked out, and we actually assessed 11 lateral flow kits, 11 different ones, to see which was the most promising. Then my team's main work at the time was what we call study 2 and 3, in fact, which was, well, study 2 was the acceptability. I mentioned earlier I've worked in HIV and sexual health, and there's a lot of self-testing going on in that area, particularly for HIV in parts of Africa where we've worked. But to make those tests useful in terms of public health and in terms of individual clinical care, people have to be able to use them and have to be willing to use them. So we need to make sure that, first of all, people find them acceptable. Are people happy to do a finger prick test? Can they do the test? How many people manage to get the test? And so we worked intensively with 300 people, 300 members of the public who volunteered to work with us, and we asked them to use the kit. We got feedback, we looked at the instructions, they helped us, they commented on them, we interviewed, and we developed a very good package, we think, so that they could be very usable. And we then tested that by sending those out to, actually it ended up being just under 15,000 randomly selected adults, to say, to see how many of them could use that. I'll show you the results briefly. And once we were happy with that, we thought, well, now we're ready to take this out into large studies in the population. So the first of those, the laboratory evaluation, we have essentially created a pipeline. We've published this in the journal Thorax, but we created a pipeline for test evaluation. We had the 300 members of staff who were known to have had positive PCR, and we also tested these kits on 500 stored serum from before the pandemic, so from last year. So we knew that they did not have SARS-CoV-2. We deliberately picked healthcare workers rather than hospitalized patients, because people in hospital and have severe disease may mount a very, very strong antibody response. And what we wanted to know is whether or not these antibody tests would work in the community, people with a range of different severities of disease. And we compared those with new gold standards which were being developed, gold standard tests which had been developed at Imperial as well. So we were working very closely with the diagnostic people and the virologists and the immunologists in the clinic, in the laboratories at Imperial, to get the best possible tests. So what do these tests look like? And this is eventually what we designed with designers and with members of the public as to what the kit that arrives if people sign up for these tests. They get this little packet, they get linked to a video where they can see it being performed, and they get all the material they need, a little lancet to make a finger prick, etc. And then this is the cassette I was mentioning. So you drop the blood into this well. A lot of people do a bit of splattering of the blood, as this one is here. You drop some of the buffer into this one here, and then after a certain period of time, 10 to 15 minutes, you read the results, the number of lines telling you different things. And everybody who does these tests is asked to upload a photograph. So actually one of the challenges that we've had is how to store what we've now got 360,000 photographs, just like this one. One is how to store them. Secondly is how to read them. And so we're working with the computing department to get machine learning to read these, so we can check what see whether or not we can get a system in place where a machine learning program can check what the person has said the result is and how they've interpreted it. Usability, as I mentioned, we did this large studies and 14,000 adults were asked to take part. 97% were able to complete the test, and 95% got a valid result, which means it was either positive or negative. And there was good concordance. We did this by eye, actually, with about 600 of the tests. Clinicians, well, myself and another clinician, we looked at the results and we compared what we designed it with what the individual who'd done it had said, and there was very good concordance. And this here, you probably can't see it very well, but it was very easy to do, you know, the finger prick with what. So we tested two different lateral flow kits, and one was much more easy than the other, but we chose the one that was performed best in the lab and performed best in this situation. So finally, we took it out. Well, finally, this was the first one we did, end of June, we went out to a random sample of 100,000 adults. We were not allowed to do this in children. The Health Medicines and Healthcare Regulatory Authority wouldn't permit us to do this in children. In fact, we were only allowed to do it in adults they gave us special permission because these were not designed and have not been approved for use by individuals at home. I mean, they are being put through that process now, but we were doing this for research purposes only. So we measured the prevalence nationally and locally, compared groups. We used this random sample self-test, and we were able to track the epidemic. So a few results. This is from the first round. We've now had 3 rounds, and we're just writing up the second and third rounds, but I'll come back to that. So essentially, what we found was that the prevalence overall was 6%. That was positive tests out of the total, virtually 100,000 tests. The reported prevalence is slightly different than if you just divide one by the other, because we adjusted for the test characteristics, which is something you can do at a population level. So we know how many it's likely to miss and how many it's likely to falsely say are positive, and we adjust for that. But I just wanted to point out a couple of things. There's no real difference between men and women, much higher in London. So this is measuring cumulative prevalence, how many people over the period of the epidemic up to the end of June had developed antibodies. So 13% in London, compared with, say, under 3% in the southwest of England. This chart on the right shows age groups, so the highest prevalence in, this is 18 to 24 and 25 to 34, nearly 8%. Lower in the working age population, then 65 and 75 plus, much lower prevalence. And then one of the most striking things, I guess, of all was ethnicity. In people of Black, African, Black Caribbean and Black other ethnicity, 17% prevalence, compared with around 12% in Asian and other, and 5% in people of white ethnicity. So we were able, through this method, to show the striking inequalities. And this is not in how sick people became, this was whether they had been exposed to the virus in the first place. This shows a few more things. So these bars over here are just showing an increase odds ratio, so how much more likely you are to be infected or to have antibodies. So this shows healthcare workers who are patient-facing, about twice as likely as others, as non-workers, non-healthcare workers, to have antibodies. Care home workers who work directly with care home residents, more than 3 times more likely to be to have been infected. This is the ethnicity data I just showed you. This here is household size. So you see a steady increase. The more people and the bigger the household, the increased prevalence that you had, or increased likelihood of having the virus. Slightly higher in more deprived than less deprived areas of the country, and also higher if you had reported having had severe symptoms, if you thought that you'd had any COVID symptoms. One of the interesting things that one of the things I found most striking when we got the data and started looking at the data was this chart on the left here. So this dark line here is a plot, a sort of smooth plot of the weekly deaths from COVID that were reported. And this shows the highest deaths were in the middle of April, middle to end of April. So this daily deaths. Then what we plotted is this is the date of infection. So for those people who tested positive in our sample, antibody positive, those who had reported symptoms and thought they'd had COVID, most of them had not been in hospital, not had a test at the time, but they thought they'd had symptoms. And we plotted the dates that they said they got those symptoms. And I was shocked at how closely it tracked, just predated by about 2 to 3 weeks, the deaths. So that, I think this shows it's measuring something very real, and it's a good way of estimating the shape, timing and distribution of the epidemic in retrospect. A couple more brief things. This plot shows for January, February through to June, the proportion of cases by ethnicity. So you see in all months, the overwhelming majority of cases were in people of white ethnicity. But you see an increasing proportion in minority ethnic groups as once it spread and lockdown. As lockdown was implemented, it got more concentrated, if you like, in Black, Asian, mixed and other ethnic groups. And we think that is because of increased exposure due to those groups being more likely to be in occupations where they were at higher risk, such as healthcare workers, care workers, in transport and so on, whereas it was more likely, or not most white people, but more white people would have been protected by being able to work from home. These, again, they're very pretty, like wallpaper, but this is by region, and I just show this, and each different colour is a different region, doesn't really matter what they are. I'm showing that there were cases across all regions across each month. So this wasn't something that was mainly or only in one region. It actually started off, it was introduced from January onwards right across the UK, or England, in fact this is. Yes, there were more cases in London, but it really was very widespread throughout. And by employment, again, this just shows the top one is healthcare, the red and the light and dark orange are, the yellow, this one is here, you can't see this, but this kind of third one down is care home workers. And as the epidemic went on, a greater proportion were healthcare workers and care home workers, showing actually the failure of PPE in those sectors and the failure of infection control in health and care in May and June. The final bit of data I'm going to give you is about the infection fatality ratio. This is something that, as an epidemiologist, we're very keen to find out. So this is not the proportion of cases of a disease that die, it's the proportion of all infections that die. So that would include people who don't get any symptoms, don't get sick. And overall, the way we estimate this is we take the population size, so this is the size of adults in England, which is 56 million, apply the prevalence that we know from the antibody study that we've done, we get the deaths that have been reported up to that point in time, which was those that were confirmed with COVID on the death certificate, and then we work out an infection fatality ratio. So it was just under 1%, 0.9%. So just under 1% of all people getting this are likely to die. And then we did it by age, showing it's very low in the younger age group and goes up to nearly 12% in the 75 plus age group. We also looked at it by age and sex and ethnicity, and we showed that the infection fatality ratio is very similar in white, Asian and Black, once you control for age and gender, age and sex. So this was actually a very novel finding, so that the increased deaths that we see in Asian and Black populations do seem to be entirely explained by the increased risk of getting an infection, not because you're going to get a more severe infection once you are in a severe disease once you're infected. So from this, we've shown that the impact is socially very unequal. We do need greater protection. I'm quite pleased that by doing this very large public engagement and usability, we've shown you can use these home tests for surveillance research. And we've done a lot of public involvement, and I think that's been key. So in conclusion, I haven't talked about all the other research that's going on at Imperial. I know you've had other talks available there on YouTube from friends who've talked to epidemiologists and people doing diagnostics, and there's various talks up online. But I started off by saying one of the key things about public health was trust. Early on, the first thing that I was interviewed with actually on the television was about the infodemic. This was in February. And there was so much information about coronavirus, nobody knew. And I think it's just gone on and on and on. It hasn't gone away, this both good information and bad information, incorrect information. And I think that has really made it difficult for us to build a trusting communication with members of the public about what they should be doing. And I think that's one of the reasons why there has been a resurgence, that there just isn't the trust in the messages that are coming out. And I think that's very challenging. And I do think that places like Imperial have a role to play. Again, early on, right at the end of January, we decided to build a course. I work with Coursera, in fact, the online educational provider, and we worked with them to build a course on, we called it Science Matters, Let's Talk About COVID-19. We had no idea how big this was going to get, but we were already worried. This is last week in January where I first proposed this. And we developed a course. It's had, I think, 150, 170,000 people have taken this course online now. And I think that by sharing the science, by talking about how we arrive at our conclusions, that's one way to start building trust. So I'm very pleased to be able to do this talk today, because I think these kind of things where we're sharing science, improving science communication, I hope, and I think that's a start, and we need to spread this kind of ideas out. So as you can imagine, a lot of people have been involved in the work that I've described here. This is just some of them from the investigators. It's led by Paul Elliott and Aradazi, Graham Cook, myself, and others, Wendy Barclay and Christina Atchison, Stephen Riley, who's done one of your talks before, Crystal Donnelly and Deborah Ashby, who are statisticians. And we've got the Department of Infectious Diseases, clinical virologists, and people from the Institute for Global Health Innovation, my own team in the Patient Experience Centre, public partners, designers, and Ipsos Mori. So that's that, and I shall stop sharing my screen and open it for questions. Thank you.
Thank you very much, Helen. That was incredibly informative. I think a lot of us would like to go with slides and get them and say, okay. But let's go to the questions. One of the things I failed to do, talking about communication as you were, I failed to communicate that if you'd like to put a question forward, please type it into the chat window, and that helps us to look at them and see which ones are repeated, etc. And in all of your talk, we've just got a single question so far, so please keep them coming in. This is from John Talbot. In fact, it's a two-phased question. We're making 250,000 tests per day. How many people are tested daily, and how many of those people are newly tested?
Good question. What I've been talking about is research testing, which is over and above the 250,000 that you're talking about then. Most of the people that are tested now in the pillars 1 and pillar 2. So pillar 1 is a clinical testing, NHS related testing and Public Health England testing. Pillar 2 is the testing through the private providers and Serco and the drive-through ones and things like that. So the pillar 1 is people who need it for diagnostic reasons, so hospitals or contacts who've been traced in that way. That's the pillar 1. And the pillar 2 will be people who have mild symptoms or who've been recommended to get a test. So when you go on 111 and say, I think I've got this, or you have been said you might be a contact and have been recommended to get a test. Now, that's changed. And I know, as I'm sure many of you do, a lot of people who've got kids who've gone back to school or who've got kids at gone to university, etc. And there's an awful lot of, there's a lot of demand for testing from people who are concerned because they've got very, very cold-like symptoms like fresh as flu, as we used to call it, or the sniffles that kids get when they go to school. So I think a lot of the testing is being taken up by them. So it's very difficult to interpret the results of those, I have to say, which is why we think that doing this systematic, active surveillance in the community is so important. And
to follow up on your point about the worried well, how many of those people are repeat tested and how many people are newly tested?
We don't know. The data are not.
Oh, okay.
Are not, as far as I understand it, certainly in the pillar 2. It's not at the moment. It's not clear how many are repeat testers. Eventually, we will be able to look at that.
And one from Alan Grant: is there evidence yet of transmission from school children to their grandparents?
I don't know. Again, I'm not doing the public health local surveillance. We certainly know from studies in the US and elsewhere and in India, there was a study recently published, you definitely can get transmission from school children to adults. I'm not sure whether anyone's looked specifically at their grandparents, but if they can transmit it, they will be able to transmit it to anyone. I'm not sure there's much evidence that there's any lower risk of transmission from children than from anybody else.
Okay. One from Rod here is actually coming through thick and fast. One of the disadvantages of when they come through thick and fast is that the question you're trying to read goes up off the screen. So I'll try and get this quickly out to you before it does. So how will your work inform future epidemics, and can it change our approach? And is there anything being done in the US, similar work also being done in the US and other countries?
Okay, excellent questions. So how will it change things? Well, first of all, the REACT-1 study it's highlighted quite how rapidly this has been increasing recently, and that has already informed government. I can't prove at the moment that people may not like this if I said this was the case, but certainly the tightening of restrictions, the rule of 6, the changes that have been introduced in the last few weeks have been informed by various sources of data, including very influential this REACT-1 findings, because they were quite surprising about how high it had gone. The antibody study, I think the influence that I'm hoping is already having is to identify those groups that are most at risk of getting the infection, not just of getting sick, and therefore showing quite how much more work we need to do to protect certain groups. So we can identify groups and geographic areas that have been particularly heavily hit. And the methodology we will be able to use in a kind of surge capacity where we think there's outbreaks in the future. To go in and do a sort of mass testing in a systematic way across a city, you'd be able to isolate where it's being transmitted and which groups need most protection. Other countries, I'm not sure that anyone's got the same scale of this as the REACT studies. A similar study was reported from Spain, looking at antibody prevalence. And of course, we have other studies in England and the UK, like the ONS studies, which are doing a slightly different design, but doing similar and complementary kind of surveillance. But yes, I think our surveillance is probably, I'm not going to say world beating because that would be to paraphrase somebody else, but it's fairly extensive compared with most other countries, and there's nothing like this in the US.
Okay. And then moving down the screen, right, oh, this is quite an interesting one. From all the testing, etc., and test results, do we have anything like a ranked list of contact scenarios that are likely to lead to infection?
That's a great question. Not yet from this. We are looking at the data to try and do that. I mean, the React one, which is the best one to get recent infections, because we're asking people, and they could have been infected 3-6 months ago. So the React one, which looks at a recent infection, we've only just started getting the number of cases where we could start looking at that. But from other data and from other outbreak investigations, singing in a choir is definitely one of the highest risk things, or being in a choir where there is public singing in close proximities. And
right.
I think we know about most of them. It's enclosed, it's inside rather than outside, being close, and things where you generate aerosols and so on. So singing, shouting, teaching.
So if you must go to a concert, go to a classical recital.
Go to something very, very quiet.
Okay. And what from Deborah Channon now? What is the percent of false positives in testing?
It depends what tests you're talking about. So the swab tests, which is probably what you're referring to, the PCR test, that depends on the cutoffs that are used, and it depends because you've probably heard that these PCR tests, they're detecting RNA, and they will detect dead RNA as well as live RNA, if you like, or RNA capable of infection. But if you set the cutoff right, then you can be pretty clear that, so that if you have a low cycle threshold, you can be looking for essentially viral load, which is an indicator of virus. But in the public testing, I don't know, because they don't publish that data. In our testing, we're pretty strict on it.
Yeah. Okay. So that is quite and there's a related question here, which is I think you've described the antibodies test that you've explained, but maybe there are different types. And how does a COVID swab test, and how do the antibody COVID tests actually work? So maybe what's inside the liquid mixing with your blood to create the line?
So the COVID swab, so the swab test, which tests for the virus, it's actually testing for the RNA of the virus. And what I'm not a virologist, but essentially you take the swab, you put it into a liquid, or you can use a dry swab. Then they have to be taken to the laboratory where they extract some of that, or they extract that RNA if it's there, and then amplify it to the point where they can then detect it. And what I'm saying is the more cycles it takes to amplify, the less of a signal there is. So that's how that one works. With the antibody testing, essentially you get a protein, you identify one or more proteins in that is an antibody. So an antibody is a response to the virus in the body, and you can detect these. And what's in the test kit is basically another protein that will latch onto one of those antibodies, and then when you put the buffer and the blood on, if the antibodies are there, they will then generate a colour, which is the line that you see. So that's a very sort of simplified version of the way it works.
And now there's a question from James Head, which actually speaks to what you've just explained, which is the reports that the PCR test may be positively identifying latent or degraded virus. I think that was addressed in your comments now. So I'll skip over that. Thanks, Sir James. I'll skip over that to Paul Carwood, who's seen estimates from different countries of infection fatality rates. And your figure of 0.9% is the highest one, I think, that he recalls seeing. And what's your view on general estimates? And if I can jump on that as well, is there any information that suggests that the fatality rate is changing. So I'll let you answer that, both of those questions.
Okay, so the fatality rate is an interesting one because it's almost entirely dependent on the age distribution of cases. So our 0.9 was actually excluding deaths in care homes. You included them, it went up to about 1.4%. Because in care homes, the fatality of people infected was extremely high. Now, that's not surprising. They're very often, not all, but often very frail elderly people, very vulnerable to infections, have a high fatality from flu as well. So, but if the majority of your cases are in younger people, you're going to get a lower case fatality. So actually giving a single case fatality rate is not, in my opinion, very helpful. You need to look at age-specific case fatality rates. And in fact, although having said that, in Spain, the result was almost identical to ours based on a similar methodology, about just under 1%. Is it changing? We don't know yet, but I would hope so as we get better at managing people. But at the moment, we don't know because we haven't got data, say, from the second wave of infections. But the main thing is the age of the people who get infected. So if lots and lots of young people get it, then the overall infection fatality rate will go right down.
Yeah. To fold these into a question that Rod said about epidemics, we're supposed to be going into a second wave now. What will you be doing to your methods and your work results and reporting for this particular phase of this epidemic? Is anything going to be more intense or change?
Well, we're doing larger numbers going forward. We were doing 100. We're going to be doing 150 to 200,000 each time, so that we can get better, more granular local estimates. So that's one thing that we're doing. As I said, we may well be looking at doing expanded testing in. For example, it would be very useful to be testing in universities at the moment, care homes, but there's other studies that we will be collaborating with to use similar methods there. We do evolve our questions, if you like, to ask about things that have become relevant and important. So yes, travel, for example, our current round has got more about travel overseas, so we can see whether or not more recent infections are more common in those who went away over the summer. So we're evolving the study. There are a lot of sort of offshoot and linked studies. So we are going back, for example, in the antibody test study, REACT 2, we're going back to people who've had antibody tests, and we're asking about the impact of those tests and the results on their behaviour. We're trying to see whether or not if somebody does have an antibody positive test, whether or not they then think, oh, I'm fine, I must be immune. Because we say we don't know whether you're immune.
Yeah.
And we're very clear you should not change your behaviour. But people do all sorts of things. And so we're going back to test that. We're also, most people have given us permission to access their to link to their medical record outcomes. So we're going to be looking at how common long COVID is in people who've had antibodies. We will be, we're going to go back to some people and do some genomic studies. So there's a lot of other things that will go forward.
And that's great that the cohort is then, collaborating with you on more coming through. So I'm going to scroll, and this is from Colin. Is the antibody test the only means of testing if a person has been infected in the past?
It's the only common way that's used. You can do other assays on T cells and B cells, which require more complex testing. But basically, the antibody is the only kind of one that can be applied to large numbers of people. There are many different types of antibody tests, and we are doing several different types. We have another cohort of key workers, police, and some fire officers that have had both the finger prick tests and the swab tests. They've also had blood tests taken, saliva tests, and we're kind of using them or working with them to test the tests to see if we can get any new methods. So that's where we're working with some of the laboratory diagnostic developments that Imperial's right at the forefront of.
Okay, fantastic. Thank you. Rod's saying he's missing his choir practice, so he's...
Sorry about that. Good though.
Good. There's a lot of virtual choirs going on at the moment. Yeah. And now from Keith, what evidence is there that coronavirus can affect an individual more than once?
There's a few, well, this particular coronavirus, there's a handful of case reports of people who are known to have had it before and who got it with a different genetic fingerprint, if you like. So you know it's a different case. We know that coronaviruses in general, you can get them multiple times, not the same one, but closely related ones, you can get them repeatedly. It's one of the reasons why we were and continue to be so worried about this, is that people do develop an immune response. That immune response is protective probably in the short term, but it does tend to wane after a few months or several months.
Okay, that's a good question. And an equally good one now from Deborah Shannon. Ethnicity is complex, especially in London, as I'm sure you appreciate. Part of the proportion of people employed in public-facing professions and part is skin colour. The recent study shows that vitamin D makes a difference to outcomes. Is this relevant?
Yeah, I mean, you're absolutely right, Deborah, that when we look at the ethnicity, say we found that in the first round that people of Black ethnicity were 3 times, just on the basic crude analysis, were 3 times more likely than white people to have antibodies. But then when we controlled in our analysis for public-facing jobs such as healthcare and care work and other key work, and for where they lived, so living in London and Birmingham, the big cities, for population density and for socioeconomic status. So those kind of things that we know affect your risk otherwise, then that reduced that association. It didn't get rid of it completely. There was still a 2-fold increase. But so you're right that some of that is, and I would say probably a lot more than we were able to control for, is due to those structural factors that mean that people in Black and Asian and mixed ethnicities are more likely to be put at risk. The issue about skin colour itself, I think there's very little evidence. I mean, because the ethnicities, all non-white ethnicities, were at increased risk, which tells me this has got nothing to do with genetics or skin colour. It's just people who don't declare themselves as white. It's people I would say it's about structural racism primarily and structural inequalities. However, it's true that vitamin D has been shown in some studies to make a difference, but mainly to how sick you get, not whether you get it at all. And what we've shown is that there is big variation in whether you get it, not how sick you get. So I think there's ongoing work on vitamin D, and a lot of people don't find that very convincing. Other people do. It's certainly good for other conditions to take vitamin D if you don't get out very much, and or if you've got dark skin colour.
Well, I mean, the skin colour is only a visible part of your head.
Yes, exactly.
There's lots of heritage that a person may still end up with a skin colour that is black, but they may be descended from a mix of races, and it's very difficult to do that sort of study unless you then go back in history or something.
Yeah.
Yes, and another topical question from another chorister in our committee, who's also gone virtual. This is Alan Grant. What is the best approach to dealing with misinformation from certain politicians? I've heard young people I know repeat these beliefs, e.g. flu is the same outcome as COVID. Over to you.
Well, I have to be careful and don't get me started on the way I would deal with President Trump. It's not really for discussion in this forum. But
Yes.
I think that the misinformation and the downplaying, it's, it is certainly has been associated with populist politicians and is very damaging. I think how you deal with it is really complex. I think you have to try and do simple patient education. You have to listen, not just be condemning, show evidence and so on. But I know that, in some ways you're fighting a losing battle when you've got such very powerful machinery of things like Facebook that end up amplifying many of these messages. It goes back to science literacy, health literacy, actually political literacy. So it's a big thing to challenge. And I think we can just try and be calm and clear and evidence-based in what we say.
One thing that comes to mind is we visited the Imperial College's Data Science Institute a couple of years back. And at the time they were showing us how Twitter influenced the Brexit vote. Has anyone done any research into social engineering to make us all nicer online and more balanced and informed? Is that a strand of React as well?
No. I think, we try to be as collaborative, cooperative, and as we can with everyone, whatever their views and so on. But I think if you really want to do research on that, Imperial's not best placed probably for its research on social science. I do a lot of work with social scientists, actually. My team includes a lot of social scientists, psychologists, anthropologists, but Imperial's not got a humanities or social science faculty, which I've always thought is a bit of a shame, but we collaborate with those in others. And there are a lot of people working on digital culture about how rumours, for example, spread and how one might counter them.
Yeah. Okay. And then lastly, again from Deborah, if the CFR is low for young people, should we be allowing our students to get COVID and thus decreasing the R factor for the rest of the population?
Well, if, yes, the case fatality rate or the infection fatality rate is lower in young people, it doesn't mean it's not a serious disease in young people. Some young, not very many, very small numbers will get quite badly sick, but quite a lot will get chronic post-viral syndromes from what we're seeing now. That is of a concern. So I would say it's a concern for them. We wouldn't just say, well, just let everybody get whatever it might be, HIV or, we have said it in the past about measles because most people are fine, but actually even if 1% of them get seriously ill, that it lasts for life, a lifetime of chronic chest complaints in people who had measles when they were kids. So that's something in their own right. But the problem, if that's not a problem in itself, the bigger problem is that there is no way of restricting contact of young people to older people unless you want to be a completely divided and not have anybody. Who cares for older people? It's younger people, and people do live in mixed families. So
not everyone's in hall of residence.
No, and people, as you see it if you visit Imperial, there are workers in the halls of residence who are older, who are probably vulnerable in other ways. What are you going to do about that? Sack them all and get only people under 25 are allowed to work here? All the people like me might not allowed to work because I might mix with a young person. So I think it's in theory, you might be able to isolate them out, but you'd never be able to mix again.
Yeah. Okay. And a last one so far from Keith, who says, do you think Her Majesty's government is still following the science? So another provocative question. Over to you.
I would say actually this is probably a good one to finish on. I don't think there is any such thing as the science.
Yeah.
Science is a method and an approach and a way of testing your hypotheses. It's a way of knowing better, understanding better, intervening, but constantly testing and challenging and testing and challenging. So the idea that there is a science which has an answer, there isn't. But I certainly think that the government is not listening to the advice of public health practitioners and professionals who themselves synthesize, or should synthesize, the best available science at that point in time and present options. Of course, it's up to the politicians to choose those options, because sometimes they're not, there are trade-offs, and as we've seen. I actually don't think it is a trade-off between the economy and health, because I think until you can really control the virus, the economy is going to continue to be in a very, very difficult situation. So I think we have to work much closer on how do we really suppress the virus. I am optimistic. I mean, you wouldn't be a scientist, I don't think, unless you were optimistic that the amazing work being done at Imperial, at Oxford and elsewhere on vaccines, on treatments, I think there really is a lot to be optimistic about, but it may be slow. I mean, I worked in HIV. It took us, I was working in it with HIV patients from very early on, from the early 1980s. It wasn't until 1996 that we really had the breakthrough that meant we could stop seeing so many people die. So that was 12 years from when we were first seeing cases. So, but I'm an optimistic we'll do it a lot quicker than that. And the vaccine work looks much more promising.
Well, thank you very, very much. I'd like to invite people to unmute themselves so that we can give Helen a round of applause. I'm very grateful you come along tonight, so thank you so much for that. I've been hugely informed, I'm sure we all have, and we wish you all the best in your research, and we're very grateful for your lecture.
Thank you, John.
Thank you.
Thank you.
That's fantastic.
Yeah. We'll be back online soon, and I'll hand you over to Bill now, because I think the next lecture is on Higgs cosmology, not Higgs cosmology, but Higgs particle, is it not? Please help me out here, or I'll just click onto the website while you're thinking.
Cosmology, really, John.
Is it cosmology? Right.
Well, what have we learned about Higgs that relates to cosmology? Yeah.
Okay. So join us soon for that. Once more, thank you to Helen, thank you to the committee, and thank you all for joining in tonight, and we hope to see you at the next lecture. Bye for now.
Thanks very much.
Thank you all.
Bye.
Thank you, Helen.
Bye.
Thank you.
Thank you, Helen.
Thanks.
Thanks, Rodden and Bill and Angie. Cheers now.